So we need a framework that helps us think about so-called high-risk parents, which again is not a particularly nice term, but it's a term I'm using to talk about parents who are at risk themselves, given their history of abuse and trauma, of having parenting difficulties, having difficulties in that transition to being an attachment figure for someone else. And some of the people I would work with have a very clear, and I'll tone down the language a bit, but very powerful ways of describing the dilemma. How can you expect me to be a parent when no one parented me? What on earth do you mean? Get on and look after your child in an appropriate way, be a nice, warm, engaging attachment figure, when I haven't got an internalised model for that that's easily accessible, or I've got some thoughts but I'm not sure about how to actually do that. And these are the real dilemmas that abused parents face, or that parenting after abuse brings up. So these are parents we might see as fundamentally highly traumatised, where their own unresolved traumatic attachment issues, their own history, directly impacts on their capacity to be with their child, directly impacts on their capacity to parent. Now, I'm certainly not implying that everyone with that sort of history is going to suffer and be a poor parent in any sense. It's not a judgmental statement. But there will be issues, inevitably, for people who've had disrupted or suboptimal or abusive early attachment experiences, even if the issue is the whole big dilemma of how to do it differently, how to be protective of oneself and one's child in the face of that. That is a real psychological and emotional issue. We don't want to minimise that. I don't think we should be, as service providers or clinicians, trivial about that and saying to people, well, you'll be all right. People would not seek help if it was that simple. Parenting is a hard job for anyone, for all of us. And if you look at the amount of popular media that covers how to be a better parent, how to read babies, how to cope with the stress of parenting, we all know that these are huge and complex issues in our lives, but certainly more complex for those who've experienced early adversity. And people want to get it right. So the parents that I would work with, most of whom are involved in a child protection system, some of whom are very young, 14, 15 years of age, some of whom have drug abuse problems, so people who've really been struggling, are pretty much uniform in their desire, their deep felt wish to be effective parents, even if they don't know what that means. And that means I think we have to be very respectful of that as a very important motivation. So at the very least, people will be anxious, understandably, about how they're going to get it right. Worried sometimes by impulses that they might have. They find themselves experiencing impulses that they find difficult to control, feeling frustrated, feeling angry at times, feeling overwhelmed by the demands of parenting, which, again, everyone experiences on some occasion. But if that's persistent, that can be highly stressful and make early relationships even more difficult. At the far end of the spectrum, I guess, and this is not the most common outcome, pleasingly, but we certainly see people who are stuck with repetition, or where past trauma literally intrudes on their relationship with their child, sadly. Sometimes where people get involved in traumatic reenactments. So literally repeating with their own child what happened to them. Now, we frequently, I guess, see those cases in child protection systems or after the event. But I think it's of fundamental importance that we get better, if we can, at identifying people who may be at risk of repeating. And certainly taking very seriously people's presentations when they say, I'm worried that I might repeat with my own child what happened to me. I don't want to do that, but I'm really worried that that could happen. And again, reassurance, simple reassurance is not the answer to that. So we have core opportunities here for the prevention of this transgenerational transmission of problems. And sadly, we do know that abuse, maltreatment, attachment disruptions can be transgenerational, can be repeated from one generation to the next. We also know that these trauma-related themes can reverberate throughout communities where parenting and care is disrupted. And I think we also should be very respectful about the way that historical events, socio-political events have impacted on some communities. Indigenous societies would be one example, and some of the asylum-seeking families that I see where trauma has reverberated throughout societies, and many children are at risk as a result of that. Breakdown of relationships, breakdown of the attachment framework, the attachment scaffolding that societies need if we're going to function effectively. So these are not only individual psychological issues, they occur in a social and cultural and political context. And of course, we always need to, I think, be aware when we're thinking about the diagnosis of so-called borderline personality disorder that we're also talking about a fundamentally gendered diagnosis. We're talking about the real and lived experience of women on the whole in our community. I'm not saying it's entirely women, but we know that this is a diagnosis that's given mainly to women, that women are still and continue to be the most common group in our community who are the victims of abuse and trauma in an intrafamilial sense. We certainly know that trauma then can be reenacted in a gendered way, and we know that many women who have experienced early abuse and trauma are more likely to be re-victimised in terms of adult relational functioning, more likely to be in exploitative relationships characterised by violence and abuse. But we also know, sadly, that these women can reenact difficult and sometimes abusive interactions with their own children. So this is a fundamental understanding of the way in which trauma disrupts all attachment relationships potentially. Trauma, abuse of others is fundamentally an attack on attachment, an attack on meaning, an attack on our capacity to think and understand. And in the work that I do, I guess I see points of intervention where we might actually be able to intervene in that cycle by helping parents who've had these experiences think about and gain a greater capacity to manage their own feelings and their own psychological understanding of themselves, their history, their culture, their community, and also their role as parents. Now, of course, what we know about children is fortunately children are very resilient and remarkably, even in very difficult circumstances, attempting to think about that, to understand that, to influence that. And so what we end up seeing in children who've experienced trauma are really the ways in which children will attempt to adapt to that in the best way that they can. Now, you've heard something I understand about the sort of neurodevelopmental aspects of this, which is some of the work that I'm doing at the moment, but fundamentally important that we think about the way in which children manage stress in these highly stressful situations, particularly if they're chronic and ongoing, and the way that that can impact on brain development and the development of the whole range of psychological capacities that we need for later functioning. But children in situations of threat and danger, which essentially is what being abused is about, are children who will cope with that in the best way that they can by going on survival mode. They're on, if you like, in that survival mode, on the lookout for danger, often hypervigilant. Makes very good sense if you're in a hostile or threatening environment to actually monitor that environment very closely, monitor the people who might be threatening, and to be very focused on that level of interpersonal functioning. So even though these are children and babies who might look quiet and reserved and be not particularly responsive in an emotional sense with people around them, they are highly observant, hypervigilant, on the lookout for danger and primed to self-protect, which is a very adaptive and very important process that happens very early. That is adaptive at the time. That's not to say that that's necessarily adaptive 20, 30 years down the track, but it can and does become part of the way in which the nervous system and brain organises itself developmentally. To be primed to self-protect, primed to respond if that's what's called for. So there are long-term effects of nervous system development around stressful experiences. Cortisol, the stress-related hormone, of course, is one that's particularly important in a range of physical processes, stress regulation, but also things like to do with physical health, things like regulation of blood sugar, blood pressure and so on. And so not surprisingly, some of the long-term follow-up literature that you're probably familiar with, looking at the physical health of people who've experienced abuse and neglect, will find increased rates of things like high blood pressure, essential hypertension, type 2 diabetes. So other physical responses that may be understood in a trauma framework being related to these very excessive amounts of cortisol, excessive amounts of early stress. So not only is the psychological and emotional health of people who've experienced trauma compromised, but physical development can be compromised as well. We need to be very aware of that. Now, the reason infancy, the first 3-4 years of life, is potentially so important when we're trying to understand these pathways is fundamentally because it's a period of rapid change. Our brains are growing at their most rapid rate early on, and a lot of the wiring's being laid down. So that's the biology. To think again a little bit about the fundamental emotional tasks of parenting. And this helps us, I think, understand where we might consider intervening and psychological therapies. Having a baby, becoming a parent, is obviously a hugely complex thing for anyone. Coming to terms with this new person, being able to understand the communication of the infant. If we see babies as fundamentally very social people, being able to engage with them, to cope with things like dependency, normal anxieties, which everyone experiences about dependency, about the delicacy of babies, about how am I going to cope if I feel frustrated, tired. You know, this is very, very normative. And I guess what we're trying to relate to is the way that these normative developmental processes, normal parts of becoming a parent, actually impact on those who've been traumatised. And I think that's very important in a service provision context to understand, because these issues, these anxieties can be very overwhelming at the time of birth and shortly afterwards, and can actually be a reason for people presenting to clinicians or to mental health practitioners, being overwhelmed by anxiety, being paralysed and feeling frozen with the absolute responsibility. Many parents who've been abused and traumatised having recollections or memories of things that have happened to them in the past in a post-traumatic way are not uncommon in services. Now, whether our maternity services on the whole and our obstetricians and so on, our system of maternity care is oriented enough to understanding trauma presentations, I think it probably isn't. But these are very real experiences that some women will have around the time of birth. Establishing relationships with a new baby, coping with the physical relationship, the closeness, particularly for women who might have experienced sexual abuse, can sometimes be an issue. And yet we have a system at the moment that's very keen to encourage everyone to get out of hospital as quickly as possible, establish breastfeeding as soon as possible, not admit to any tiredness or fears or anxieties. And we don't have the luxury that we might have had some years ago of people actually spending a bit of transitional time in a supportive environment with staff. It's back home, get on as soon as possible sort of thing, which means we're going to miss some of these trauma responses in women. So again, being alert to trauma early on is very important. Then there's the issue of coming to terms with who the actual baby is. And sometimes these, again, are quite complex issues. So the parent who really wanted, let's say, a baby of one sex or the other and ends up with the opposite one, or who had a particular idea about how the birth experience would go and how that was meant to be, and things turned out differently. These are all factors that can really impact on people's lived experience of becoming a parent. There are ideas and wishes and expectations and hopes that someone develops about the baby to be during pregnancy. And those are very important, but then also that there needs to be a process of coming to terms with who the actual baby is. and there's not much choice about that, obviously, at that point. But these, again, are very important issues, particularly we need to be addressing them antenatally for women who've experienced abuse and trauma. The baby is a very powerful person. The baby can be a new and very positive relationship for someone who's experienced abuse or trauma, a chance for that baby to have positive parenting in the way that the mother herself might not have had, a chance to do things differently, a chance to really start again. So these are crucial times where if we have the right sorts of supports and interventions, we can actually be working with people to help them understand and rework their own experiences of trauma and see the way they can be a nurturing and protective person to their own children.